Hello and welcome everyone to tonight's webinar, exploring GP diagnosis and management of bipolar disorder, and also a little bonus on the history of lithium, which is actually quite interesting because it was an Australian who discovered how lithium can help in bipolar disorder. Before we start, we would like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also extend that respect to any First Nations people joining us for tonight's event. I'm Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me is Kunal Mohiti, the Events Lead at Capital Health Network, and of course our expert speaker, Psychiatrist Dr. Llewellyn Lewis, and also Kirsty from Rainbow Mandela, Dr. Lewis's private rooms. I'll soon hand over to Dr. Lewis, but just a quick outline about how the event will run. So please type any questions or comments into the Q&A box on your Zoom screen, and we'll have a Q&A session once Dr. Lewis is finished. And I'm sure you will have lots of questions. The webinar itself will be uploaded to the Capital Health Network YouTube channel, and you're welcome to rewatch it or share it with your networks. And also please feel free to self-report 1.5 hours of educational activities to your CPD home. So now over to Dr. Lewis. Dr. Lewis is a consultant psychiatrist with over 25 years of international experience across South Africa, the UK, and Australia. Dr. Lewis specializes in innovative and evidence-based treatments, including ADHD, an approved prescriber for psilocybin and MDMA, and is actively involved in clinical research with the Australian National University. Dr. Lewis leads Rainbow Mandela Clinic and Therapies and continues to advance contemporary mental health models and clinician education in the ACT. So thank you very much, Dr. Lewis, and I'll hand over to you now.
Thank you very much, Leonie. So good evening, everybody. My name is Lou. It's such a pleasure to be here, and thank you for the opportunity to teach you folk about bipolar disorder in Australian general practice. So what we're going to cover today is diagnosis, acute management, mania, hypomania, and mixed and depressive exacerbations, and long-term care. So as Leonie was saying, I'm a general adult psychiatrist. For most of the week, I work in the Home Assessment and Acute Response Team, or Crisis Team Service at the Canberra Health, and obviously encounter many patients presenting with deteriorations in mental state, including emerging hypomania or manic episodes. Some of the time I'm doing research in psilocybin for treatment-resistant depression, and the rest of the time I'm working in the private practice. So what we're going to cover today is how to recognize and differentiate bipolar 1, bipolar 2, cyclothymia, and mixed features, and how to conduct a safe, time-efficient GP assessment, including risk assessment, the medical rule-out, and comorbidity, how to initiate evidence-based acute management of mania or hypomania and mixed or depressive exacerbations, and how to plan ongoing maintenance, pharmacotherapy, psychoeducation, relapse prevention, and physical health monitoring. And then knowing how, when and how to refer to psychiatry or the emergency department, medico-legal considerations, involuntary care, and capacity. Okay, so just a brief historical overview. In ancient times, descriptions of mood disorders can be traced back to Hippocrates and Plato, who both documented extreme moods such as depression and mania. In the 19th century, French psychiatrists Bipolar and Referral independently described the condition, calling it folie à double forme and folie circulaire, respectively, which in English means madness in two forms and circular madness. In the late 1890s, a famous German psychiatrist, Emil Kraepelin, categorized manic depressive illness as a distinct psychiatric condition. He also described a schizophrenia, calling it dementia precox. In the 20th century, in the 1950s, lithium was discovered to be effective in treating manic episodes. John Cade was a Melbourne psychiatrist in the late 1940s who embarked on investigations in the asylum that he was working in and discovered that lithium was effective. I have a presentation about the interesting story of John, and just want to say that he's an unsung hero. Much more should be written about him because of the immense contribution that he's made to psychiatry. In the 1980s, the term bipolar disorder was introduced in the Diagnostic and Statistical Manual version 3, replacing manic depressive to reduce stigma. And in our present century, there's ongoing research into genetic and environmental factors influencing the disorder. So in terms of its epidemiology and burden, the point prevalence is 1% of adults. There is high functional impairment with this condition, and there is a 60 to 70% lifetime comorbidity with both anxiety and substance use. And it's very common for there to be a delay to the diagnosis, commonly more than 6 to 8 years. And misdiagnosis as unipolar depression is frequent. So the importance of education for primary care specialists like yourselves in identifying this condition will help us improve those delays in diagnosis, hopefully. So your role is obviously early recognition, safety planning. Once acute treatments have stabilized the person's mental state, ongoing shared care for maintenance and prophylaxis of future episodes. And of course, the interplay between physical health and mental health, side effects of some of our medicines, which increase morbidities, cardiovascular illness, and the like. So your role in the physical health screening and management of those conditions is very, very important. So the key syndromes are bipolar 1. I won't go into the DSM-5 criteria right now. I'll read those after I've presented a brief case. But you need to have at least one manic episode, plus or minus hypomania and depression. So if a person presents for their first episode with a mania, you can confidently diagnose them with bipolar disorder because a depression will inevitably ensue. Bipolar 2 is a condition where the degree or the extent of the functional impairment of a mania is not necessarily there. It's a milder but very serious form of the illness, and these patients may not require hospitalization for the hypomanic episode if you're able to intervene appropriately. They do have major depressive episodes in addition. Cyclothymia is more of a subsyndromal presentation where people have more than 2 years of fluctuating hypomanic and depressive symptoms which don't fully meet all the syndromal criteria. There is a mixed features specifier in the DSM-5 where patients may experience concurrent manic and depressive symptoms with relatively more of the manic or depressive symptoms and relatively less of the vice versa. And this is associated with a much higher suicide risk and poorer outcomes. So in primary care, you'll be taught a little bit about screening prompts that might help you identify these conditions. But in summary, you're asking for past periods of elevated or irritable mood and increased energy. And you might use the mood disorders questionnaire or other tools to help you screen for previous episodes of, in particular, hypomanic episodes. These aren't diagnostic, but they do give you clues. And what you're wanting to differentiate the condition from is any substance or medication-induced states. Stimulants like ADHD treatments and corticosteroids can induce manic states. Antidepressant-induced hypomanic and manic states are also a cause, but they may, if the symptoms are persisting, those conditions can be diagnosed as bipolar or bipolar 1 or bipolar 2 conditions. You're also differentiating from personality disorders where emotional instability is a feature, such as in a borderline personality disorder. Other conditions like complex PTSD with irritability, marked emotional lability, and you're differentiating from some anxiety disorders and ADHD. And the medical causes are things like hypothyroidism, Cushing's, encephalitis, meningitis, and sleep deprivation. So very importantly, assessing risk and safety. The immediate risks in these conditions are suicide, self-harm, harm to others, neglect, vulnerability, changes in capacity, and then absconding from hospitals, for example, risky behaviors, spending excessively, driving too quickly. Indications for the emergency department or urgent psychiatry are any of these. Escalation into delusional thinking, auditory hallucinations, very severe agitation, again, escalation in suicidal or homicidal intent, severe functional decline, clearly pregnancy with mania, and lack of capacity. And the legal and practical applications, obviously in the ACT, emergency apprehensions to the emergency department, where involuntary assessment may be necessary, and detention in hospital. If someone is taken to the emergency department under an emergency apprehension or an EA, that could be through the PACER team, the Police Ambulance Clinician Emergency Response Team. It might be through paramedics. It might be through mental health officers who are involved when the crisis team are involved. That will result in assessments in the emergency department within 4 hours, and then a decision to either detain the person under emergency detention for 3 days, or to revoke the emergency apprehension and let them go home. When you're assessing these patients, it's really important to document the risks, the capacity, and any collateral information that you're getting from family members, people they live with, etc. So the usual approach is your history and the examination. You're looking for when the onset of the symptoms were, how long they've lasted for. For mania, the criteria in the DSM-4 are that they should have persistently and abnormally elevated, expansive, or irritable mood, and abnormally and persistently increased goal-directed activity or energy lasting for at least a week. Present for most of the day, nearly every day, and or any duration if hospitalization is necessary. Obviously, if you're starting to see signs of mania emerging in an established case, you're not going to wait a week before you admit to hospital. But it's in the cases of undiagnosed conditions that the time criteria is considered to be important in making the diagnosis. You're going to look at triggers. Has there been sleep loss? Are they using any substances? Is there recent trauma? Have any medication changes happened? Are they in the perinatal period? And of course, a mental state examination will go without saying. You might, if possible, do a brief neurological examination. Absence of focal signs, and things like apyrexia, etc., is leading you towards thinking this is a mental illness presentation rather than an organic driver for the behaviors. The tests, the routine bloods, which are listed over there. You might do urine toxicology, a pregnancy test where relevant. Often it's difficult to do ECGs in patients who are hypomanic, so that is usually done after the antipsychotics are usually initiated. And obviously, as we've mentioned, collateral from family and partner. If they've been keeping a sleep diary or a mood chart, there are lots of apps nowadays where patients keep track of their sleep, energy, appetite, etc. So that data can be very useful. Many people wear Fitbits and smartwatches, so data regarding sleep patterns and the like might be available on those devices too. The acute management, immediately non-pharmacological interventions, if possible, trying to reduce stimulation. If there are plans to go partying all night and you're starting to see this behavior emerging, trying to encourage the patient not to do that and to try to go to sleep if possible. You might need to provide sleep assistance. We'll talk about pharmacological management later. Safety planning, limiting access to finances, taking away the car keys, treating substances or withdrawal, and ensuring hydration and nutrition. The pharmacological principles, broadly speaking, we'll go into some detail about this later on, is the use of antipsychotics, plus or minus mood stabilizers for acute mania or hypomania, and importantly, to avoid starting antidepressants in acute mania or mixed states, even if there are depressive features, and ideally stopping antidepressants. Tapering is usually not something that we do in acute mania. We immediately stop the medication because it's driving the mania, and we can deal with any antidepressant discontinuation syndrome in hospital with drugs like benzodiazepines, for example. So the diagnosis, which I've touched on, is not always that easy. Eliciting the history of mania and hypomania is essential, and it might seem obvious. Oftentimes we see it when it's at its end stages and hospitalization is inevitable. But hypomania might brew for many months before someone develops or escalates into mania. And these states can be very easily missed. I'm talking from personal experience. The other thing is that patients usually don't seek help when they're feeling hypomanic. They're enjoying themselves, they're being very productive, they're getting stuff done, they're being very creative, they might be quite fun to be around. So patients only really seek help when they're depressed. And patients who are depressed tend to have a negative recollection bias about past events and can be unreliable historians when you're asking them to remember past elevated states. Similarly, if the highs are not disruptive enough, they may not be recognized by patients or families. So how do you increase your diagnostic hit rate, as it were? So focusing on mood neutral symptoms, when you're getting a history from someone sitting in front of you, can you remember periods previously when there was marked increase in energy, where you felt very restless, where you were engaged in lots of activity, with a reduced sleep requirement and not feeling tired, where you had lots of ideas and multiple projects undertaken without completion. So these are mood neutral symptoms, and they're oftentimes better recollected than the mood symptoms, which actually form the fundamental criteria for diagnosis. You're also looking for remembering the consequences of disinhibited behavior. So can you remember a time when you spent so much that you got yourself into debt? Or can you remember embarrassing behaviors that you feel ashamed about right now, when you were reckless or when other people commented on you? So at this point, I'm going to stop, and I'd like to read a personal account of a young person's experience of mental illness in her own words, which has been given with permission. It was 1992, an exciting year for all 18-year-olds who had been accepted to university. I attended the Rand Afrikaans University in Auckland Park. Two of my classes, statistics and industrial psychology, were held in an auditorium which seated 300 students. At our first lecture, we were told to look to our left and to our right, and we were told 2/3 of the class would have dropped out before the year's end. That really hit me, but something hit me harder. I was driving along the M2 South Highway in Johannesburg to university one morning. It was a beautiful, sunny, big blue sky day, a typical high-felt summer's day. There was a news broadcast. A dear friend of mine, JB, who had attended Sandown Primary School with me, had passed away in a tragic car accident. The fact a peer, a dear friend, had passed away took the wind out of my sails. It brought mortality home. I experienced the worst panic attack ever. At the time, I didn't know what a panic attack was. It was terrifying. I felt lightheaded. I couldn't breathe. I was hyperventilating. My extremities were tingling. I had butterflies in my tummy. I started to derealize. Eventually, after what seemed like an eternity, my heart rate slowed down. My pulse normalized. I could breathe. Tears streaming down my cheeks. Pure relief. I was shaking, but I was okay. Little did I know highways would become the enemy. I just could not face a long stretch of road with very few exits and cars speeding by on either side of me. Trips to uni and other places became much longer, arduous. I had to take long scenic routes where I knew I'd be able to pull over or escape down a side lane should I have another attack. Panic attacks were to become the norm. Constantly there, an uninvited friend. Sometimes I could feel them coming on. Sometimes they came out of the blue. These kinds would knock my socks off. They would blow me away. On one occasion, when I was on my way to uni, driving my brand new car, a gift from my parents, a massive attack hit me out of the blue. I literally stopped on the side of the road, pulled up the handbrake, left the engine running and the radio playing. I left the front door open and sprinted up the hill, pulling my hair as I went, somehow hoping the pain would ground me. I didn't give a thought to my car or my belongings in it. To this day, I know there must have been a guardian angel standing over me because no one stole my vehicle, and that is a miracle in South Africa. I started experiencing fear of the fear. It was debilitating. I stopped attending lectures. I would visit a friend of mine who was in the final stages of his fight against AIDS. When the end of the lectures came around each day, I would make my way home. No one knew I was skipping uni. I didn't lie. I merely hid the truth. Very unlike me. That period came to an end. A new friend arrived. Agoraphobia. It was a very difficult time. Here I was, a young girl with my future ahead of me. I couldn't leave home. I couldn't even walk all the way up the driveway. Our pavement was out of bounds. Depression set in. Days and nights merged. Pajamas were my standard attire. Sleep became a dear friend, a sweet escape. When my mum asked me how I felt, I recall my words clearly. I feel like I'm in a dark black hole and I cannot get out. What I used to be able to do with a plume had me stuck. I had no confidence. I didn't even trust myself to write notes at university. My folks loved and encouraged me all the time, and eventually we made an appointment with a psychiatrist, Dr. J. Enter tofranil, otherwise known as imipramine. Those little white tablets started to make me feel a lot better. My confidence was returning, energy was high, and by week 3, I was firmly out there, even wearing clothes some might consider risque. With time and 2 white pills a day, I started to blast out of my shell. I was able to move into the apartment my parents had bought for me. It started slowly. I started going out in the day and at night. My outfits were becoming more skimpy. My spending habits became excessive. I even asked strangers, suppliers of my folks, for a loan. My flirting hit the charts, and I simply knew I could fly. Literally, I knew I could fly. I was extremely confident. I felt like I was the most beautiful girl in the world. I was the one dancing on tables at nightclubs. I was hyper-religious. I was very talkative. I felt very attractive. Approaching strangers with a 100% hit rate was an everyday thing. Speeding in my car everywhere ended up with me being arrested by the police and being locked up in a cell for an evening. I was wearing ripped stockings, high heels, and short shorts at the time. I was very thankful they did not lay a charge against me. Further to that, a friend of mine and I were involved in a car accident. We were blessed there were no serious injuries. To frame my state of mind at the time, we merely jumped into a taxi and went out dancing. Frivolity. Sleep was a thing of the past. I could go days without it. In an average week, I would need to rest one day. Studying for exams was a night before thing, and my results were exceptional. I even blew myself away. Attending nightclubs every day of the week had me causing chaos. Releasing tear gas on occasion had bouncers chasing me down. Fortunately, I got away. Spray painting over a wall mural at another establishment had the staff wanting to sue me. I'm most grateful they let me off with a warning. And chatting to strangers and inviting them to my apartment became the norm. I was taking serious risks, and I lacked insight and capacity. Several people thought I was on cocaine. Albeit I acted this way, miraculously, I never came to any harm. The intervention. My parents invited my brother and me to their holiday apartment to enjoy 2 weeks of sun, sea, sand, and quality family time. I had been residing in my apartment, and my family weren't aware of my antics. The drive to the coast was 5 hours, and I sang along to every tune on the radio. I never kept quiet for a moment, and my brother was getting more and more irritated by the second. That was the beginning. It became apparent to my folks and brother that things weren't quite okay. In fact, they were far from normal. Aside from me singing the songs on the journey and being very talkative, I made it very clear to my brother that I could fly and that landing on the roof of the restaurant across the road from the apartment at the sea would be easy. Then there was the fact that I wasn't sleeping at all. And I ran all the way to Durban city centre to borrow money from one of my folks' curtain suppliers. I didn't know them at all, but they accommodated my request because of who my parents were. I spent all the money on skimpy clothing, which I wore when I arrived at the beach to meet my brother and mom. They were no doubt shocked. My mom packed up her stuff and left the beach. She was not having it at all. I promptly left the beach and made my way to a beach bar for a drink, where I met a very good-looking gent. I told him we were going to get engaged. I had images of many engagement rings in my diary, and I invited him up to my folks' place so he could meet the family and we could decide on the ring. You can only imagine what my family thought at this stage, let alone the poor gentleman. What was planned as a lovely family holiday turned out to be quite stressful 2 weeks for Dad, Mom, and brother. When we got back home, my brother, who was doing his psychiatry block of his medical studies, sat me down in the family room and asked if I was feeling very happy. My immediate answer was yes. He asked if I would be open to seeing a psychiatrist. Again, I said yes. Apparently, this is half the battle won. The first thing I noticed when we went to Dr. S at Sunninghill Hill Clinic was the number of patients who smoked. I'd always detested the habit, but taught myself to smoke when I was going high because I thought it looked cool. I'm really grateful to have stopped smoking 12 years ago. It really is one of the worst things one can do. Dr. S prescribed lithium. It took 6 weeks for the meds to kick in. I was back to me, and it felt good. I stayed on my meds, ate healthily, and exercised for 30 years, never experiencing a manic episode again, but having numerous depressed ones. Various antidepressants and mood stabilizers were added over time. In 2023, I was on business in Johannesburg for 4 months and met with 3 friends who told me I didn't really need to take my medication. Stupidly, I stopped taking them in February of 2023. In May of 2023, 3 months later, I had a manic psychosis, which resulted in the police arriving on the estate where I live. They were very kind and put me into the back of their van and took me to the psychiatry ward. Most of the experience is a blur because I was sedated and heavily medicated. My hospital stay was 6 weeks. Lithium was started again. Upon discharge, I experienced 6 months of depression and anxiety with a very slow recovery. But I'm glad to say now I've been enjoying stability for 1.5 years. A key learning for everyone to be compliant. So my sister was happy to give permission for me to share this account of her experience. Of relevance is the history that my paternal grandfather experienced a manic depressive psychosis in 1955. And he spent 9 months in an asylum in Johannesburg, recovering only after receiving unmodified ECT. Lithium was unfortunately not available in South Africa at the time. So that's an account of a family experiencing someone having a hypomanic episode. It started off with a panic attacks, which were then treated with, in those days, they used tricyclics, imipramine. That then resulted, following her depression, with an escalation into hypomania and subsequently into mania. And of course, of significance is the family psychiatric history of a grandfather with a manic depressive psychosis. So it's easily done, though, when you're wanting to help someone with depression or a panic disorder. It's really important, though, to get the history. So helpful pointers to aid the diagnosis are a family history of bipolar disorder, onset at an earlier age, a relatively recent diagnosis of depression, history of brief recurrent episodes, abrupt onset or ending of episodes of depression, atypical presentations such as oversleeping or eating, or lethargy, depression with catatonic or psychotic features, postpartum mood disorders, and a seasonal pattern. If you've got patients with depression who've been treated with multiple antidepressants with a poor response and relapses, or an accelerated cycle of depressive episodes, or the induction of symptoms of mania, then you're heading towards a diagnosis of bipolar disorder. The mood disorders questionnaire is a very useful screener, and I'll just go through some of these questions. You can find them in the screener, but if you reflect on the account that I've just given you, things might or might not have been spotted. So has there been a period of time when you were not your usual self and you felt so good or so hyper that other people thought you were not your normal self, and that got you into trouble? You were so irritable that you started fights or arguments. You were much more self-confident than usual. You got less sleep and you didn't really miss it. You were talkative and spoke much faster than usual. Thoughts raced through your mind. You were distracted by things around you and had trouble concentrating or staying on track. You had more energy than usual. You were more active than usual. You were more social or outgoing, telephoning friends in the middle of the night, more interested in sex. Did things that were unusual for you and that other people might consider excessive, foolish, or risky. Spending money. If you've checked yes to any of these, have several of these ever happened during the same period of time? And how much of a problem did it cause you, like being unable to work, having family problems, money or legal troubles, getting into arguments or fights? Have you got any blood relatives with a manic depressive or bipolar illness? And has a health professional ever told you that you have either of these conditions? All right. So how do we manage acute mania, hypomania? So antipsychotic monotherapy is often the first step in the private practice and in the emergency department. Olanzapine is a very easy medication to prescribe to patients. It doesn't require any monitoring acutely. You can add it to most existing drugs. In the crisis team, we liberally use this if we are encountering people with psychosis or hypomania. Starting with, if they're naive, you might start with 5 milligrams, but you might need 10 or 15 milligrams, and it's very sedating. Quetiapine is useful as well, but it's a little bit more tricky to start, because if you go in at 300 milligrams, which is probably what you need, maybe even higher than that, for hypomania, they might have significant orthostatic hypotension. I don't tend to use risperidone in the acute phase if someone is naive. Again, they have hypotension, orthostatic hypotension with risperidone, and you can't go in straight away with 2 or 3 or 4 milligrams. You normally have to titrate it. Similarly with aripiprazole, it's a good antipsychotic, but if you're giving people this atypical antipsychotic, there is a risk of akathisia. It can cause insomnia, and what you really want to do is get on top of the sleep. Oftentimes prescribing aripiprazole, you have to give lorazepam or diazepam at the same time to get over the akathisia. So it's a bit more complex in terms of, more drugs, but olanzapine, in my opinion, is a good one to start with. I was talking to Llewellyn before we jumped on, and I've got a number of patients with bipolar disorder who just have a supply of olanzapine in their medicine cabinet. If their usual mood stabilizers are not working because they have intercurrent stresses or a physical illness or something which is triggering a hypomania, then I advise them to take 5 milligrams of olanzapine or 10 milligrams of olanzapine. They don't have to ask my permission for it. They can call my clinic the next day. But this is one way of getting on top of an emerging hypomania very quickly. If there's a partial response to those first line steps and you can add in other medicines, it's easier to use a benzodiazepine because if you're adding lithium, that usually is a conversation that you want to have with patients once they have a bit more insight, because it is a commitment. If you're going to start lithium, there's obviously the monitoring that's required. And we know that if patients are not adherent with the lithium, their risks of relapse into hypomania or mania are very significant. In my sister's case, the lithium kept her very well for 30 years. Within 3 months of stopping it, she was in a hospital. So that's usually how long it takes for them to relapse. Valproate is a really good treatment. You can load them with 20 milligrams per kilogram. So this is what we used to use in the late 90s before olanzapine was on the market, available in South Africa. So you'd give someone 1 gram of valproate and then, or 1.5 grams, depending on their weight. And then you would see a resolution of hypomania and mania within about a week. In those days, there weren't as many concerns in females of reproductive age. Of course, now you wouldn't be prescribing valproate because of the teratogenic effects. So with mood stabilizers, the target for acute mania is between 0.8 and 1 millimoles per liter. Again, it's not something that we start acutely in someone who is naive to lithium. Patients who have been manic for a while often are dehydrated, and you'd worry about toxicity. But you could certainly introduce it once they start having a little bit more insight. And the usual monitoring, which I'll get into detail about later, is what is required. I've mentioned valproate at 20 milligrams per kilogram. Carbamazepine is a third-line anticonvulsant mood stabilizer. It's a bit more tricky to initiate because of if you go too quickly, they might develop ataxia and unsteadiness on their feet. So the top ones to go with are the antipsychotic mood stabilizers first. When you're using carbamazepine, it does induce its own metabolism. So you have to increase the doses over time because the blood levels reduce as the doses increase because of the enzyme induction. In terms of hospital thresholds, call the crisis team if you're worried. We can go out and see them, usually same day within a few hours, and we can get the olanzapine started. If someone is presenting in your emergency department, acutely manic or psychotic, you'd call an ambulance. And the paramedics would then enact the emergency apprehension. But severe agitation, psychosis, mixed features are all high risk and will require hospitalization. So when you've got exacerbations with mixed manic and depressive features, so now the person may be cycling out of a depression into a mania or is cycling out of a mania into depression, and there's a mixture of both of these types of symptoms. They're very risky, high suicide risk. You just need to prioritize the anti-manic strategy. Stop the antidepressants if they're there. There's no need to do the tapering. You don't have time to do the tapering. You want to stop the medicine that is driving the mania. And here again, the usual options, olanzapine. You can use quetiapine, aripiprazole, as I said on the first slide, but our go-to is usually olanzapine. And the non-pharmacological treatments, tighten sleep hygiene, reduce stimulus. When people are settling down, there might be aspects of emotional regulation skills that they might learn in dialectical behavioral therapy that can be useful. And very importantly, involving supports. Carers are often, or partners are much more likely to notice the emergence of early warning signs of relapse than the patient. So if there's an observation that they're not sleeping, they're watching more TV, more talkative, then that might be the point at which activation of a safety plan is done. And you may consider admission at lower thresholds if you're concerned. So the stepwise algorithm for acute mania or hypomania is triage their safety risks first, reduce stimulation, start the antipsychotic, plus the benzodiazepine if required. If there's a partial response, then you might add in another mood stabilizer. You might admit if there is inadequate containment, high risk, or need for rapid titration. And in the crisis team, we would normally step them up into intensive home treatment and see them twice daily. When they start settling down, we will reduce the frequency of contact to daily, and then we will step them down to second daily. And hopefully we will avert an admission to hospital. So the burden of disease in this condition is high. With bipolar depression, there is a high morbidity, high comorbidities, and high rates of mortality. Bipolar affective disorder ranks in the top 20 of all medical conditions in the Global Burden of Disease study, and BPAD is 6 amongst all the mental health disorders. Bipolar patients spend half their lives unwell, most in partial remission in subsyndromal states, and more often than not, it's depression. And that has been the experience that my sister has had. The subsyndromal states are much more common than these acute states that I've just been talking about. And they actually cause the most functional impairment. They will impair someone's ability to go to work. They can cause challenges in relationships. They can interfere with education. So they are very, very debilitating and chronic conditions. Depression is, as I said, the commonest. It's 3 times more common than mania in bipolar 1 and nearly 40 times more common in bipolar 2. And it's for that reason that bipolar 2 disorder is a more risky disorder in terms of rates of suicide. The diagnosis of bipolar 2 may be challenged, as I've described, and it may be misdiagnosed as borderline personality disorder. Just a quick update on borderline PD. Here they have emotional lability in the dimension of calm to anger. These affective states are short-lived, their mood remains reactive, and the affective changes are directly associated with internal and external stresses. There may be high levels of impulsivity or hostility, especially if acutely stressed. Oftentimes there are interpersonal difficulties, deliberate self-harm, oftentimes to ease tension, and histories of childhood sexual abuse. When you're considering rapid cycling bipolar affective disorder, this can be sometimes misdiagnosed as BPD as well. It's a concept or an entity that was introduced in 1974, and it is diagnosed if a patient has 4 or more depressed, manic, or mixed states a year. So that's cycling every 3 months. It used to be attributed to unopposed antidepressant treatments, but Emil Kraepelin, the German psychiatrist, did describe it over 100 years ago before antidepressants existed. It can start at a young age. The lifetime risk is 16%. A third of people with bipolar disorder have a rapid cycling course, and it's more common in women, and there is an association with hypothyroidism. When you're looking at the comparison with borderline personality disorder, here the emotional lability isn't in the anger euthymia range, it's in the euthymia, depression, hypomania dimension. Unlike borderline personality disorder, where the changes happen over days, sometimes several times a day, here there are sustained mood changes over days to months. In people with borderline personality disorder, there's that emotional reactivity, whereas in people with rapid cycling BPAD, there is reduced reactivity of mood. And this mood change is associated with physiological changes of sleep, appetite, and mood congruent cognitions. And they don't have interpersonal difficulties usually when they're euthymic, unless there's comorbidities, but their personality is normal when they're euthymic. So comorbidity is the rule. Anxiety, substance use, and thyroid disorders are commonest. And this is what makes recognition of bipolar disorder more difficult. If you think back to the case I've spoken about, we had panic attacks, agoraphobia, and depression. The suicide rate is 15 times higher than the general population, and we've spoken about the higher rates in bipolar 2. Suicide risk in bipolar depression is 35 times higher than in mania, and more so in a mixed affective state than in a pure manic state. So when you're talking about death rates due to natural causes, these are higher in patients with bipolar and unipolar depression. Many of us know about the oft-quoted statistic that people with chronic schizophrenia, for example, die 20 years earlier than their general population. There are similar younger rates of dying in people with bipolar and unipolar depression. They have a higher risk of cardiovascular disease due to obesity, smoking, diabetes, hyperlipidemia. Some of the medications that we prescribe increase the risk of the latter two concerns, which is why if you're starting someone on olanzapine to acutely manage a mania or hypomania down the line, it's useful as a rescue medication. For some patients, it can be very effective for prophylaxis, but oftentimes the preference of patients is to switch to a more metabolically neutral drug like lorazepam, aripiprazole, brexpiprazole, etc. So switching focus now to bipolar depression. Bipolar depression is the commonest presentation in 50% of people with bipolar disorder. And in the absence of mania, it's not possible to make the diagnosis of bipolar affective disorder. No research or clinical discriminators nor biomarkers have yet been identified, but as we've already touched upon with the mood disorders questionnaire and specific questions and family history, there are a number of pointers and screening instruments that can assist the diagnosis. In bipolar depression, as GPs, we recommend quetiapine monotherapy. The dose of quetiapine that has an antidepressant effect is about 115 milligrams. So you usually titrate upwards from 25 to 50 to 75 and then up to 150. The anti-manic dose of quetiapine is 450 milligrams. So you have a range there between which hopefully one is able to treat both the depression and the hypomania. Quetiapine, the studies that were conducted back in the 2000s were the ones that identified it as a proper mood stabilizer, which means stabilizing both the hypomanic and manic dimension and the depressive domain, a lot like lithium, which is the gold standard mood stabilizer. Lorazepam monotherapy might be useful or an adjunct to lithium and valproate. And lamotrigine is a very good antidepressant mood stabilizer. It doesn't have any anti-manic or anti-hypomanic effects. So lamotrigine is very good for bipolar depression. Avoid antidepressant monotherapy if you are unsure and if there are any of those historical features that I've spoken about. If used, always with a mood stabilizer and specialist oversight, and screen for mixed features before choosing therapy. Again, non-pharmacological interventions like CBT, family-focused therapy, managing sleep, exercise, etc. And for depression with psychosis or catatonia, obviously an admission to hospital is indicated. All right. So this might be less relevant if you're not using valproate, but it's useful to know if someone is on valproate or is going to be started on valproate. It does push up lamotrigine levels. So if the patient has been started on lamotrigine and you want to protect them from a mania, you might choose quetiapine instead of valproate. But if you do add valproate, then you need to halve the lamotrigine dose, because within 2 or 3 days, the lamotrigine plasma levels will double, and you're obviously concerned about the Stevens-Johnson syndrome. So just be mindful of that interaction. If you have got on top of the hypomania with valproate and you're thinking of adding lamotrigine to assist with the depression, then just halve the dose of the lamotrigine and increase it much more conservatively than you would otherwise. When you're adding lamotrigine to carbamazepine, remember carbamazepine is an enzyme inducer. I would still be conservative with lamotrigine. I wouldn't go in at double at 50 milligrams. I'd start at 25 milligrams because it's safer. But if you're adding carbamazepine to someone who's on lamotrigine, then because of the enzyme induction, the lamotrigine levels may well reduce. And you might want to watch for depressive symptoms and then tweak the lamotrigine up if needed so that they don't become depressed. All right, in terms of monitoring and physical health, we've touched on this already. The target for depression prophylaxis is around 0.5 or 0.6, depending on which lab you're sending the blood tests to. Remember, if you're taking blood levels for lithium, they need to be 12 hours after the last dose. If you're thinking someone is on a lowish dose and is starting to become hypomanic, then bump up the dose. Usually, I recommend 450 milligrams of slow release to start off with. We do, prior to starting, we do baseline kidney functions, including EGFR and thyroid. And then we start the lithium, and a week later, we repeat those blood tests and do the lithium level. Sometimes people are scraping into therapeutic, but more often than not, they're at 0.3 millimoles per liter. So we then double the lithium level, the lithium prescription to 900 milligrams. And then a week later, test again, and so forth. And you're trying to get them into a therapeutic range. You can monitor the thyroid functions and kidney functions 6 to 12 monthly. If they start to develop elevations in thyroid stimulating hormone and lower T3s and 4s, then you can add in L-troxin or thyroxine, 50 micrograms, 100 micrograms, and treat the lithium-induced hypothyroidism. Valproate, as I said, it's quite easy to initiate that, 20 milligrams per kilogram. It comes in 500 milligrams. You might do BD dosing. You can sometimes do lactate dosing. You can monitor the LFTs. There's no real point in monitoring drug levels because you're assessing their clinical response, and that doesn't really correlate with any established levels per se. Clearly be careful about pregnancy. So if it is a woman who's failed other first line, second line mood stabilizers, valproate might be very helpful, but they just need to be advised about the risks of teratogenicity. It's spina bifida that is an increased risk with valproate. And with the antipsychotics, it's usually for the olanzapine and quetiapine ones, monitoring glucose, HbA1c, your cholesterol and etc. You don't need to do that with the drugs like paliperidone or risperidone necessarily, or with lurasidone and aripiprazole. If you are prescribing paliperidone as an antipsychotic, then just monitor their prolactin levels. Similarly with risperidone. Okay, that's the monitoring. When you're looking at relapse prevention, it's all about psychoeducation, learning what the early warning signs. We talk about relapse signatures when you're developing a safety plan, because patients will often follow the same trajectory into a relapse with the same sorts of early warning signs. So it might be a change in sleep pattern, it might be a increased energy, it might be increased goal-directed activities. If you are able to identify that relapse signature, as one might call it, then you're able to intervene far more quickly. And again, sharing that relapse signature with family, carers, partners, etc., that will help the person have an intervention more as quickly as possible. Psychological interventions include interpersonal social rhythm therapy, which is a sleep-wake stabilization therapy, CBT, family-focused therapy, and again, psychoeducation. Lifestyle, importance of exercise, diet, smoking cessation, managing the cardiometabolic risk aggressively. All right, so we're going to move on now to women of childbearing potential and perinatal. So if the person is pregnant, avoid the valproate, as I've said. But if there's no alternative, then document informed consent, the use of contraception, and involvement of a specialist. The preferred options, lamotrigine, some antipsychotics like quetiapine, olanzapine, aripiprazole. These can be used during pregnancy. Perinatal red flags are if someone is developing a postpartum psychosis, it's an emergency, they need to be taken to the emergency department or contact the crisis team immediately, because those are very brittle states that can escalate very, very quickly, and there are risks, obviously, of infanticide. So when you're using mood stabilizers in pregnancy, and this includes lithium, olanzapine's metabolism is unaffected in pregnancy, so it's an easier one to use, but there are higher risks of gestational diabetes and large babies. Quetiapine can also be used, but in the third trimester, there's a reduction in plasma levels due to the CYP2D6 induction. So monitoring mental state, especially in the third trimester, with tweaking of the quetiapine dose upwards so that they don't escape control. Aripiprazole levels also are reduced in the third trimester. So similarly, making sure that you have regular reviews so that you can bump up the aripiprazole. It might be they're normally okay on 10 milligrams. You might need to go up to 12.5, 15, 17.5 milligrams with the aripiprazole. Lithium is a bit different. Here the levels reduce in mid-pregnancy and increase in the third trimester. So just monitoring blood levels monthly until 36 weeks, and then weekly in the last month, and continue the lithium peri-delivery. With lamotrigine, the levels drop in pregnancy. So you might, in this case, do pre-pregnancy levels, although I'm not sure of how many labs do it in Canberra. There aren't any therapeutic window guidelines, but if the blood levels decrease, then increase the dose by 20 to 25%, and then post-delivery, reduce the dose. But use your clinical judgment. If the depression worsens, then just increase the dose. All right, touching on postpartum psychosis, we're getting close to the end of this presentation. So this was more than 7,000 patients in the UK who were studied using a prospective and retrospective design. A fifth of the bipolar patients had a postpartum psychotic episode. So it is risky and it's important to do the monitoring that we've just spoken about, especially of the mood stabilizers. But a previous history predicted future episode. The risk was much higher in patients with bipolar 1 and with bipolar 2 a lot lower. Generally, postpartum psychosis happens in 1 in 1,000 women. So the highest risk is obviously in bipolar affective disorder. And there was some comments in this study regarding childhood abuse. It appears that there is an increased risk of postnatal depression, but not postpartum psychosis in people with a history of childhood abuse. All right. So moving on now to long-term maintenance pharmacotherapy. Here, the goal is to prevent the recurrence of mood episodes, ensure long-term stability. The challenges are often relapse due to non-adherence. You heard the case of that I've shared with you. Stress, substance abuse, life generally. Key strategies are to enhance resilience, regular monitoring, and to clarify that relapse signature that I spoke about earlier. Developing an emergency care plan that involves the GP, family, or partners in the care plan development. So foundational options for long-term maintenance are lithium. It is one of the only medicines we have in psychiatry that has evidence for reducing suicide and the lethality of suicide. Quetiapine, as I've explained, it is an archetypal mood stabilizer, stabilizing both the mania and the depressed dimensions. Lamotrigine, especially for depression, and we've spoken about valproate. The adjuncts are all these other drugs we've spoken about, and the principles are to continue the regimen that achieved remission when tolerated. And you can aim for minimum effective doses, simplifying the regimens to once daily dosing if possible, and then addressing side effects proactively. People on lithium can sometimes develop a tremor, which can be quite embarrassing for them. So using beta blockers to stop the tremor is helpful. So shared care pathways, when to refer when there's undiagnostic uncertainty, frequent relapses, treatment resistance, comorbidity, pregnancy and complex risk. This is ideally team-based care, multidisciplinary, and the follow-up rhythm after an acute episode. This would be done through the crisis team, for example, before discharging back to the access team in Canberra, or 1 to 3 monthly in primary care, if they've got the usual supports and are functionally or able to return to their pre-morbid functioning. So just prescribing pearls. Switch risk is possible when antidepressants are used in bipolar depression, so avoid monotherapy. Lithium does interact with non-steroidals, ACE inhibitors, angiotensin, receptor blockers, diuretics will increase levels, dehydration, and toxicity. Dehydration will increase the risk of toxicity. With valproate, weight gain and tremor. Antipsychotics we've touched on, depending on which ones you use, akathisia, extrapyramidal side effects, and considering long-acting injectables in patients who have challenges with adherence. Once daily dosing will improve adherence, psychoeducation, and involving the family. I won't do this case vignette because we've run out of time, but we've already discussed a case. I think I'll leave that for you to read at your leisure. But we do ask in this case vignette, what features have alerted you to the possibility of bipolar depression? Which features will you look for in assessing the mental state? And what other info would you like to support the diagnosis? I give you the answers there. We've covered this already. History of brief recurrent episodes, family history of bipolar disorder, poor response to antidepressants, atypical presentations on the mental state, and other features to support the diagnosis. We've gone through the questions that you might refer to from the mood disorders questionnaire. All right, and this is just a mental state examination that I pulled from one of the patients in our clinic, presenting with a hypomania. She had decreased need for sleep, severe insomnia, periods of sleeping only 3 hours a night for months. Reported speaking very quickly, feeling like she was ranting and operating at 2.5 speed, racing thoughts, experiencing ruminations, obsessional reading, fixation on certain topics, and then described a manic episode with significant emotional lability, including periods of wailing, irritability, and underlying agitation, and psychomotor agitation. Recently resumed intense chaotic dancing for up to 2 hours, and increased goal-directed activity, worked excessively long hours with minimal breaks. And it was starting to evolve into psychosis here with ideas of reference and paranoid ideation. Interpreted hidden and threatening meanings in an ex-partner's social media posts. Okay, I'll leave it at that, folks. Happy to take questions. We do have the presentation on John Cage, which is a much briefer one, and we can do that if you wish, but I think we press pause for the moment.
Thank you so much. That was really comprehensive and very useful. I just thought I'd ask a question. So, it's got two parts. So, you've got somebody, they've got a history of bipolar disorder, and you come in and they're in a potentially early manic episode. You start the olanzapine. Do you do that for a week, or do you do that for how long it takes for them to feel back to their morbid self? And then do you
Mhm.
taper down, or do you just stop?
Okay, so you would discuss with them whether they would be agreeable to take the medication. If they say yes, then you've got a win, and you can give them, 5 milligrams or 10 milligrams, depending on how agitated they are, because the principles are you want to get the sleep under control, and you want to target the elevated behavior. You might bring them back the next day to see how that's gone, or give them a prescription if there's a carer involved or a partner who can supervise. You might check in with the partner to say, how was the sleep? If 5 milligrams wasn't enough, then you can add, double it, for example. You might, however, want to refer them to the crisis team because, it's difficult to keep on top of these things in a busy GP practice. And if you've got a team that can wrap around and see them every day, twice a day, then it's a good thing to do. So do avail yourself of the heart team because we do this all the time. But it's a good idea if they don't want to engage with the crisis team, you can offer them the olanzapine as you've suggested. You might add in a bit of lorazepam, 1 milligram, because you want them to sleep. You want to interrupt this circadian rhythm abnormality, which will increase the risk of it escalating. You can keep them on the medication until they've returned to euthymia, and then you might titrate downwards. So if they were on 15 milligrams, I'd be happy to keep them on that for 2-3 weeks because I'm wanting to see a return to baseline and then reduce it down to 10. And if you're starting to see unmasking of hypomania again, then you bump it up again. And then, so it's a dynamic thing, and it sometimes can be a bit unpredictable how people are going to progress. In the wake of a hypomania like that, they are likely to develop a depression. So then you have to deal with the aftermath of that. And that might involve, you might want some guidance from a psychiatrist to give you tips on that. Call the GP advisory line. There are psychiatrists on hand who might be able to advise you. Yeah.
That's a
So
very
getting
useful
help.
point. Yep, yep.
Mm.
And the GP psychiatry line's been very useful. I've found it very useful. So
Mhm.
that's a good idea. Um, we've got some more questions. So it says, I have a patients who are scared of the side effects of lithium or stop lithium due to side effects. How can you help them to manage that?
Mm. Um, well, again, it's shared decision making with patients because if you can provide good psychoeducation and give them the options of the alternatives, then we know that the principles of shared decision-making have been shown to improve adherence. So mitigating the side effects, if it's a tremor, for example, then adding in propranolol or Inderal to see if that can calm it down. It's actually a fairly well-tolerated medication. It doesn't cause as much weight gain as the other antipsychotics. It doesn't cause as much restlessness. It's very safe. It has to be the first. If someone has a diagnosis of bipolar disorder and hasn't been offered lithium, then we're failing them, because it is a very, very effective medicine. It protects them from future episodes of mania and of depression. As you know, separately, we do use lithium to augment people who have resistant depression with antidepressants that don't seem to be working. If you add in lithium, you can often convert them to a response. But sometimes you don't win the battle when they're presented with the information that can help them make a decision, and then you have to offer them alternatives. And then it's weighing up the pros and cons of regular monitoring of lithium, for example, versus the side effects of the alternates. So what are the side effects of quetiapine? Well, weight gain, sedation, changes in blood pressure. Because of the anticholinergic effect, sometimes a bit of cognitive dulling, whereas lithium doesn't seem to do that. There are studies that look at neuropsychiatric outcomes in patients who phenomenologically look the same. So they're euthymic, they're functioning. One group of patients on lithium, the other group on quetiapine. They appear to be doing well, but when you do neuropsychiatric testing on them, the ones on lithium perform better on the neuropsychiatric tests.
That's a good
Um,
selling point, isn't it?
yeah.
Yeah. Yeah. Is there any renal function where you can't give it, or do you just reduce the dose with impaired renal function?
You've got to monitor the renal function. The renal functioning problems can be reversible if you stop lithium, but it's not as common. I can't tell you what the exact incidence is of it, but sometimes you do. If someone has been on lithium chronically for 30 years, and then they're starting to develop deteriorations in the EGFR, you may have no choice but to switch. You might get a renal consult on that, an ultrasound, and get an opinion from a nephrologist, because coming off the lithium after so long, as you've heard in the case of my sister, can be devastating if it's not done very carefully. If you do need to wean them, then you need to do it over months. So you don't stop it suddenly, and you would need to introduce something to cross cover. So I would go with quetiapine, because it's got evidence for prophylaxis versus hypomanias and depressions like lithium. Yeah.
Yeah, that's so. I have another question. You mentioned the importance of checking prolactin levels. Is that just in people with symptoms suggestive of hyperprolactinemia, or all those on antipsychotics? And if it's the latter, what levels of prolactin are a concern, as many patients will have slightly raised prolactin?
Yeah. Um, So the antipsychotics that are most implicated are the typical ones, and it's got to do with the D2 blocking, because dopamine is um, prolactin inhibitory hormone, looks like dopamine. So when you block dopamine, which treats the psychosis, you block the inhibition of the prolactin inhibition, and that results in the hyperprolactinemia. So they might have high levels of prolactin on the blood tests, sometimes like 2,000 or 3,000, but they may not necessarily have symptoms of hyperprolactinemia, like galactorrhea, breast tenderness, amenorrhea, those sorts of things. So you might not need to do anything about it. But the longer term, if there is acute, symptoms as a result of hyperprolactinemia, what you can do is add in drugs that agonize dopamine. So a trick is to add in aripiprazole, because a low dose of aripiprazole, like 5 mg, in addition to a drug like paliperidone or risperidone, which are the ones most commonly nowadays associated with hyperprolactinemia, it can drop the prolactin levels. Um, in the longer term, hyperprolactinemia is associated with bone density problems,
Mm.
osteoporosis. So if someone needs to be on a drug that, they absolutely have to stay on because it's the only thing that's worked, then monitoring their bone density using scans and the like over the years is what is required because, of course, there are risks of fractures and the like. So yeah, you can manage it by watching it, just watching and waiting. You can manage it with changing the medication, or you can manage it by adding in aripiprazole and then repeating the blood test to see if the levels are coming down.
Yeah. Yeah. It's a bit of a balancing act and a potions, isn't it? Yeah. Um,
Yes, it's a bit of alchemy.
yeah, that's right. It is, isn't it? Yeah. So I'll just put it out there. If there's any other questions, now is your chance. You have Dr. Lewis captive, and he knows a lot about bipolar disorder. So please put any questions in you have in the Q&A box. And I was just wanting to refresh. You mentioned in pregnancy that lithium is actually potentially okay in pregnancy.
Mhm.
Valproate you could use, but you'd go on the 5 milligrams of folate, would you?
No, I wouldn't use
You
valproate in
wouldn't at all,
pregnancy.
not at
Yeah,
all. So
because of the risk of spina bifida.
yeah, so even with a
Um,
high dose,
Yeah,
yeah,
I would shy away from it.
yeah,
Lithium you can use. There used to be concerns about Epstein's anomaly, but the rates are like 1 in 20,000. So if someone needs to stay on lithium because they've got a very brittle presentation and it's kept them well,
mm,
then just doing the ultrasound at I'm not sure how many weeks it is, 20 weeks or something,
yeah,
just to check that there isn't something going on with the heart. Yeah.
yeah,
So yeah, I would shy away from valproate.
at, yeah,
Um, but sometimes you have to, and then it's contraception and switching if they're
yeah,
planning a pregnancy. What you don't want is someone ideally falling pregnant without, no planning. So the education in patients with bipolar disorder is to plan these pregnancies.
pregnancy, yeah,
We've just successfully taken one of my patients who was on aripiprazole through her pregnancy, and she did beautifully. But yes, I was monitoring her monthly and then weekly at the end, and we tweaked up her dose, and there was a plan, what would happen.
yeah,
And she
yeah,
just sailed through it so beautifully. But
yeah,
she's had two manic episodes that required hospitalization before. So it
yeah,
was a high risk pregnancy, especially when
yeah,
you look at the rates of postpartum psychosis.
yeah.
So you monitor them quite closely the whole way through and afterwards.
Um, okay. Now, does bipolar disorder tend to improve or worsen with aging?
Hmm. Um, I think depending on how good you have been with adherence to your treatment, because the more adherent you are, the less likely you are to have um, a progression of the severity of illness. It's a little bit like, depression or schizophrenia. If you can get on top of the psychosis at the outset, then you're much more likely to retain functioning. When you've had one psychotic episode or a manic episode, it should be treated as aggressively as we treat myocardial infarction, because if you get in quick and you can stop the damage, then you're likely to retain the functioning, as you would with patients who, might have a heart attack, but they don't have any sequelae from,
Mm,
cardiac muscle myocardial damage, which then leads to heart failure. It's the same thing, every time you have a brain attack with a psychosis or mania, you are killing off millions of neurons, and you may not be as responsive to treatments that helped you before.
mm,
So in the case of my sister, she was only on 3 drugs. She's now on 5 drugs.
mm.
Um,
Yep.
so the natural, it's very variable, but the frequency of the episodes can increase, but that's very dependent on how well you're managing it. Yeah.
Another selling point for lithium, hey?
Mm,
Yeah.
mhm.
Um, We have another question. Is it possible to have diagnosis of bipolar with one of ADHD and I think that's meant to be borderline personality disorder? So, um,
Yes,
yep. So,
you can.
yep. So confounding things.
Mm,
Yeah.
yes. So, and both with schizophrenia and bipolar disorder, you can have comorbid ADHD. The principle is to treat the axis one disorder first. So stabilize mood, stabilize psychosis, and then once that's stabilized, then you can add in your stimulant medication. Um, they can meet full diagnostic criteria for both conditions at the same time. But you don't want to give someone with bipolar disorder a stimulant if they're not on a mood stabilizer. And if you're going to introduce the stimulant, then you might do it cautiously with a short-acting option first, like dexamphetamine or Ritalin, and then advise them if they start to notice any escalation in mood or racing thoughts and the like, then you would tell them to stop the medicine, contact the clinic, let's bump up your mood stabilizer, and then we can retitrate later on.
Mm,
That having been said, in the years that I've been doing ADHD prescribing, we've taken lots of people with bipolar disorder through,
mm,
and they do very nicely on ADHD medication. Um, and they can also have a comorbid borderline personality disorder too.
mm.
So we tend to see those. Obviously, you might not be dealing with so many of those in
Yeah.
primary care, but in a typical psychiatry clinic, you are going to get the more complex patients. Yeah.
I think it's probably quite normal for people to be complex, and it's more unusual for people to be simple because
Yeah.
that's just human nature, isn't it?
Mhm.
Um, and another question, are there any useful peer support groups, organizations you can recommend?
Peer support groups. I don't know of any in Canberra, to be honest. I'm sure there must be, but yes, I don't know. Um, Looking at places like the Black Dog Institute, that might give some resources. Um, um, in uh, in Western Australia, at the bottom of that slide, there is the Centre for Clinical, I think it's interventions, where they have various bipolar resources. Obviously, on the college website, there's information available, but I'm not aware of any peer support groups per se. Might be something to ask our patients about. Yeah, I mean, certainly being in a group and learning from other patients is useful. In the UK, we led the development of a model of care called the Maintaining Adherence Program. And it was based on work that was done by Dr. Werner Kissling in Munich. And it essentially demonstrated that psychoeducation for schizophrenia patients and bipolar patients and their carers was much more likely to reduce hospitalizations. In fact, we did a before and after or a mirror image study looking at the number of admissions to hospital in patients over 2 or 3 years before the intervention, which essentially was psychoeducation. It taught people what is bipolar disorder, what is hypomania, what is
Mm,
depression, what behavioral interventions can you do to, reduce stimulation or increase stimulation, depending on whether you're hypomanic or depressed. What are the early warning signs of relapse? What do the drugs do? It was a course that was run over about 5 or 6 weeks, and we were able to demonstrate a 70% reduction in admission to hospital, which amounted to a saving per patient of £5,000.
right.
We did
Yeah.
publish that work. So, and what was interesting was when you sat with the patients in the groups, you opened it up and they shared um, their experiences
Mm,
with, strategies to manage mood and
mm,
depression and exercise and eating and all the rest of it. And it was a very enriched
yeah.
space because it also reduces stigma because a lot of these patients feel so alone and so
Mm,
isolated and like they're the
mm,
only person having this very profound and destabilizing experience, especially if they develop psychosis with it. So
mm.
Yes, I think it's probably something that's missing. Let me
Yeah,
know if
yeah,
you find out about
y-
peer groups because
yeah,
they're important.
yeah. That sounds, I mean, what you did in the UK sounds incredible. Um, we better wrap it up there. So just thank you so much for talking with us tonight. That was really very useful for us GPs, and hopefully it'll enhance our care and improve our care for patients with bipolar disorder. So I think take-home messages as olanzapine, we can start it, and psychoeducation, and reach out to the heart team.
Indeed.
Yep, and we'll have to make an excuse to have you back next year so we can hear about the his Dr. Cade and the history of lithium. That would be great. So, on behalf of everyone here and CHN, thank you so much for talking to us tonight. And just to
Thank
remind
you.
everyone to this will go up on our Capital Health Network YouTube page in a couple of weeks. And please feel free to watch it again because there are some pearls there that you might have missed out. So thank you very much, and everyone have a good holiday, and we'll see you all next year. Thanks.
Thank you very
Okay.
much, Leonie.
Good night. See ya. Bye.
Bye.